A lady, 60 years old. She is a diabetic lady since last 25 years. In spite of using the mediatic drops prior to surgery, the pupil could not dilate very much. This is quite indicative of the doubt perhaps the pupil may become smaller and smaller during the process of phacoemulsification, because the diabetics release a lot of prostaglandins E2 while the iris is manipulated during phacoemulsification. So I am very much doubtful that the pupil may constrict during the process going on. I am doing the anterior capsular axis with a needle cystotome. I will try to make it a bit larger, of more than 5 millimeters, because of the nuclear adherence to the capsular bag, and I will try to complete it by my traditional classical approach through equator. As I told you before that the pupil might constrict, so if you can have a positive view of the anterior chamber, just have a look onto the pupil. Pupil is constricting. It is becoming smaller and smaller because of the release of prostaglandins E2 from iris stroma. This usually happens in diabetics. Pupil has become small and I have to proceed very cautiously. Two side pores are being created. And now the pupil is a bit more smaller. Now I am doing hydrodissection, and as I have done it, the nucleus is by itself out of the bag, and then when the nucleus is out of the bag and the equator is quite very much positively exposed into the anterior chamber, I have injected OVD dispersive to the posterior side of the nucleus, prolapsed nucleus, to deepen the bag. I have given a support to the nucleus by chopper, and will try to break the nucleus into the small fragments. I will take a small bites at different sides of the nucleus by means of a phaco tip with the setting of 40% phaco power, 500 vacuum and 40 cc flow rate. I am just taking small bites at different sides of the nucleus, but my main target is to keep the phaco tip exactly in the middle of the nucleus. I do not spread up and manipulate the anterior chamber all around. I always keep the phaco tip exactly in the middle of the nucleus in order to avoid the traumatic pupil capture or any accidental pupillary bite. And now I will inject a viscoelastic after the phacoemulsification is complete. Nucleus is small, but comfortably I have completed the phacoemulsification and taken the whole nucleus out by giving small tiny bites at the different spots of the nucleus and removing it gently. The aspiration is complete. Viscoelastic dispersive is being injected to deepen the anterior chamber capsular bag and to facilitate the intraocular lens delivery into the bag. This is a foldable one-piece intraocular lens with 4 haptics. 2 haptics are bleeding and the remaining 2 haptics are drilling. So this is the trifocal intraocular lens, which I will try to fix exactly into the bag, because when the focal is when the IOL is multifocal or trifocal, it should be in the bag. In order to provide a best postoperative visual acuity without any glare and haze and without any diplopia. And the lens is exactly in the bag. Now I am going to remove the viscoelastic solution from anterior and the posterior surface of the implanted IOL as well, to avoid postoperative intraocular pressure rise, cellular reaction, or any refractive surprise. We should always try to keep the intraocular lens exactly in the bag, and we should check it out that whether or not the haptics are in place. In this case, I will only inject intracameral antibiotic and dexamethasone, no pilocarpine, because in such cases, when the pupil is not already dilating and there is a tendency of the release of prostaglandin E2, Injection of pilocarpine will invite postoperative inflammation, iritis, uveitis, and sometimes endophthalmitis as well. So we should always avoid giving the intracameral pilocarpine at the end of the procedure in those cases when we do not get a sufficiently dilated pupil and when the patient is diabetic, or if the patient has got a preoperative recurrent uveitis, or when the cataract is complicated. Thank you very much for your patience.